everyone, hopefully you can all see and hear me. Welcome to our webinar on how your health data and the health data of people with cystic fibrosis makes a positive impact using UK CF Registry. My name is Rebecca Cosgriff. I'm from a small town in Lincolnshire called Boston, and I'm working from home here in East London at the minute. I'm actually celebrating my 6-year anniversary of working for the Cystic Fibrosis Trust this month, although it feels like 5 minutes since I started, I have to say. Thank you so much for joining us. The kind of order of service for today is that me and some members of the registry team are going to be taking you through 7 key areas of the work that we do on the UK CF Registry, and hopefully explaining as we go along how that work supports improvement in clinical care for people with cystic fibrosis. We're going to run through what the registry actually is, so if you're not sure, don't panic. Elaine's going to explain that to you in a second. We'll talk about our annual report, and there might even be a couple of sneak previews of the data before it's published later this month. We'll also talk about how we support Cystic Fibrosis Centre funding and research. We also monitor drug safety, which Susan's going to talk about, and I'll mention at the end how we help to campaign for access to the best possible medicines for people with cystic fibrosis. And I'll finish us off by saying a few words about the monitoring that we're doing for coronavirus in people with cystic fibrosis. There will be time for questions at the end, so feel free to type them into the chat as you go along. Amy will be responding to questions and comments as we go. And remember to stay on mute and keep your video off for the talks themselves, please. And without further ado, first up, I'd like to introduce my colleague Elaine Gunn, who's going to give a very short introduction to the Cystic Fibrosis Registry.
Hi, my name is Elaine Gunn. I've worked in the UK CF Registry since 2005. Although I've worked in CF research as a nurse since 1993 at Papworth Hospital as the database and CF research manager. I'm the clinical data manager for the registry, and I work with a great team. And I think you're just going to see a picture of that great team if the technology is working. There it goes. There's our great team. So you can see we're quite a large team. I live and work based in Cambridgeshire, but I'm a proud Mancunian girl. I guess you probably gathered that from my accent. And guess who I support? Yeah, Manchester United. So the registry started its life in 1999 as a research project based in Dundee, looking at clinical outcomes of people with cystic fibrosis. It quickly gained momentum, and in 2007 was sponsored by the Cystic Fibrosis Trust in combination with the steering committee, which included a patient with cystic fibrosis, a parent, representative, physicians, nurses and commissioners. And I just want to say straight off, the UK CF Registry includes all the devolved nations. But before any person with CF is registered on the registry, they or their parents will be given an information sheet to read and then be asked to sign a consent form. Data that's collected on the registry consists of demographic data, which includes genetic mutations and how a diagnosis of CF was made. Annually, the registry collects lung function data, history of IV therapy, chronic medications, microbiology and complications, physiotherapy and nutritional data. I won't be questioning you on what we collect at the end of this, don't worry. Most people with cystic fibrosis will have an annual review appointment at their centre for an MOT, and this is effectively where the registry data comes from. Some centres, as we get more savvy with our technology, especially in this day and age, will enter data each time a patient has a clinic appointment. The more data the centres enter means that they can query the data to help them in their centres think about how best to look after their patients with their care. For example, how many patients in our clinic have cystic fibrosis related diabetes? How many patients have chronic pseudomonas in our clinic? And obviously with cross-infection, that's a really important issue. The annual and clinic data is entered by the CF teams, sometimes by the nurses, sometimes by the administrators, even in a couple of centres by the consultants themselves. I must say, ladies and gentlemen, the quality of data entry is fantastic. In 2019, I had the great pleasure of doing a data validation visit to every CF centre to make sure data that was being entered into the registry was accurate. So just double checking that what was in the patient's hospital notes was exactly the same as what was in the registry. And you'll be so pleased to hear the data quality was over 98% with only minor errors found. But you know, ladies and gentlemen, without your participation in either allowing you or your child's data to be entered, or your centre's support in entering the data, none of this would be possible. One of the great outputs from the registry is the National Annual Report of Registry Data. Andrew, one of our medical statisticians, is going to talk in a moment about the production of the annual report and also give us a sneak preview of the 2019 data. I am very excited. The UK CF Registry is recognised as a fantastic source of data which ensures quality of CF care around the whole of the UK. If you really would like to, you can see all the reports on the Cystic Fibrosis website under the work we do. The first report on there is from 2004. Gosh, that's a long time ago. And there were 7,000 people with cystic fibrosis registered on the registry then. And if you compare that with the 2018 report, where there are over 10,000 patients with cystic fibrosis registered on the registry. Also, from 2014, we began producing a Scottish report as well. I'd really recommend you to go online. And if you don't want to read the 90-page annual report, have a look at the At a Glance report, which is really interesting, and it's much easier, 2-page read, and there's pictures. All the data is, oh, I'm really sorry, I just seem to have lost my, my notes. All the data is put together for you and your patients, and we're really grateful that you and your children with CF allow the data to be entered. We're working in a strange way at the moment in the CF Trust. We're working disparate from each other, and just like you, we're a community that aren't close together. So I'd now like to hand over to Andrew, who's going to talk to us about the annual report.
Thank you very much, Elaine. I'm Andrew Lee. I'm one of the medical statisticians at the Trust. And what that means is that I work to uncover health trends using everyone's favorite 2 topics, mathematics and statistics. And I can hear your collective groan even though all your mics are muted. So what I do day to day is I produce some of the registry's core outputs, including, as Elaine mentioned, the annual report, which some of you may have leafed through at some point, as well as the sort of more refined, accessible at-a-glance reports, along with some drug safety studies, and now and again, when I get a bit of spare time, some independent research. I'm approaching my 3-year anniversary at the Trust, and although my quickly dwindling accent might not tell you, I'm from North Belfast, and I am living in and reporting live from sunny North Edinburgh. So I'm going to take you quickly through what the annual report is and why we think it matters. So the annual report is a state of the nation style report that covers everything from BMI and lung function to medications, work, education, pregnancy, the whole shebang. It's a quick snapshot of how everyone with CF in the country is doing this year. And the good news is that if you take a stack of these annual reports from different years and go through them cover to cover, which I definitely recommend as a fun Friday night activity, then hopefully what you'll come away with is that the answer is that things are getting a little better each year. I can't give away too many details from this year's annual report before it's published in a couple of weeks, but I can say that our small CF community is growing quite large. We have over 10,000 patients for the first time this year, and one of the great little takeaways from it is that the median age of people with cystic fibrosis in the UK CF Registry has increased to 21 this year, which is roundabout saying that people are living longer, which is fantastic news. And why I think the annual report matters. It's not just because I'm a statistician, but I think there's a real inherent value in being able to count something. Because what you can count, you can compare. And what you can compare, you can change for the better. A real-world example for this might be DNA's prescription, or Dorniers alpha. We started reporting on center-level prescription rates of Dorniers alpha in about 2013. So at your CF center, you might see the prescription rates are 40% for pediatrics compared to maybe 80% at one down the road. And just by publishing that information, we facilitate the ability for people at your CF center, clinicians, to see what's going on at other CF centers across the country. And they can use that information to feed into the practices at their centers. 6 years on, we can see that the rates of prescription for DNAs have increased by 12%, pardon me, by 12% in adults and 20% in children, to roughly 70 and 60%. It's not just about what's going on in centers though. We can make comparisons about things that we're seeing across at a national level. For example, we might compare the mean predicted survival age for a child born today with cystic fibrosis between men and women. And we might see that women are struggling to reach some of the higher years that we see in men. And once we've acknowledged and sort of identified that kind of a trend, we can then hand over to talented researchers like Daniela Schultz and David Taylor Robinson, who can design studies to look at why. Hopefully I've provided you with a little bit of understanding of our annual reporting, and I'll pass you back to Elaine to talk about tariffs.
Thank you, Andrew. Prior to 2010, the payment for cystic fibrosis care was really variable, and payments were made centrally to the hospitals based on individual hospital estimations. There was no clarity on how CF care was funded around the country. In 2010, Professor Diana Bilton started working with the Cystic Fibrosis Trust, working with a pilot group of CF centres, working on a standardised tariff system. This was a huge project and involved everyone recording their time spent in caring for people with cystic fibrosis. This included nurses, physios, administrators, clerks, dietitians, all the doctors in the team, not just the consultant. And importantly, hospital stays and any home visits, the nurses in particular did. It became clear that the poorer the person with CF, the more time was required by the CF team to look after them. A huge report was put together looking at all these different pieces of information, which made a further piece of work began, which eventually put together what we call a banding severity matrix. Now that sounds really difficult to digest, I agree, and I sometimes can't say it, severity. I find severity very difficult. What this means is, if you spend more than 14 days in hospital on IV therapy, the cost would be more to the hospital team than a person who's not been admitted and not on any medication. Also, if you are on inhaled antibiotics and DNAs, this increases the cost of your journey in your cystic fibrosis journey. We also included the problems with cystic fibrosis related diabetes, nasogastric feedings, gastrostomy feeding, ABPA, and any combination of those complications carried on and made the CF journey more costly. One of the main parts of the tariff, though, is spent with the days spent in hospital. So the poorer the person with CF costs more to the CF centre. Now, after all this was reported on, and again, Professor Diana Bilton worked solidly during doing this with the Cystic Fibrosis Trust, each of the groups were attached a band. Now, not an elastic band or a hairband, but a band of care. So the less severe person with cystic fibrosis would be a band 1, and the most severe would be a band 5. It's not an easy concept with me just telling you about this without a myriad of slides for me to talk to and show you and go through the matrix. I won't say severity again. But if you do want any further information, if this is something that interests you, please don't hesitate to ask in the chat. And if we here today can't answer your questions immediately, we will come back to you if you leave an email address. So to cut a very long story short, I should have started this with once upon a time. Each band was given a cost, and this was agreed by NHS England. The bandings are generated each year based on the annual data entered into the registry. So again, your data, your child's data, the people who enter the data at the centres is paramount to make this happen for the good of caring for patients with cystic fibrosis. The tariff was first used in 2012 and then became mandatory for each CF centre from 2013.
I was giving Elaine a minute, hoping that she was just doing her own personal freeze frame, but I think she might be having problems with her internet connection. Hopefully we'll be able to get Elaine back to just finish off her talk on the tariff. But Andrew, if you're happy, I think you were up next to talk about data requests. So if you can take over, then hopefully Elaine can get back for when you're done.
Yeah, of course. And I'd just like quickly to answer a question that's been posted in the chat from Nicole, asking what does a prescription rate mean, which is a good question. And it's just the number of people, say if we use the example of DNAs, if you have 10 people at your CF center and 4 of them are on DNAs, then the prescription rate for that center would be 40%. So it's just the number of people on a given medicine over the total number of people attending that site is how we define it in the context that we're talking about. But to go on to data requests, again, I'll try and run through what they are and why they matter. So when you have a great wealth of data, like we do in the UK CF Trust Registry, the best thing that we can do to provide the greatest benefit to people with CF is to have as many bright and brilliant people looking at that data and analysing it as possible. And so the mechanism for which we facilitate this is a system in which people can complete a form in which they can ask for specific anonymised fields of registry data. So for example, if you are Laura Keeley in Leeds and you wanted to analyse the rates of lung function decline between 2015 and 2017 and how it varies with age, sex and pancreatic sufficiency status, you might fill in your form asking for FEV status, age, sex, just all the information you need for your data request. And once you've filled in this form, it's sent to the committee who handle the data requests. And this committee is independent. It's made up of both physicians, researchers, but importantly, it has representation from both people with CF and CF parents. And they decide if the research question that's being addressed is of interest, and also ensure that, you know, the people asking for the data have sufficient qualifications to answer the question and provide kind of high quality research output. So, sorry, I lost my place. To give you another example of research that's been carried out through this data request process, we could talk about Freddie Frost's works. Freddie Frost is a physician and researcher from Liverpool who was interested in seeing if we could replicate findings that ivacaftor, the CFTR modifier, was good at fending off the Pseudomonas bug that was carried out in laboratory settings, and they wanted to see if that was something that was happening in the CF population. So because we have, you know, such a wealth of longitudinal data from several years, he was able to look at information from 2011 to 2016 and show that in real patients treated with ivacaftor, they had both reduced infection rates in terms of Pseudomonas, and those who had existing Pseudomonas infections cleared them at a higher rate than those who were not treated. So a common theme in both the examples I've given, both Laura Keeley's and Freddie Frost's, is that both these projects use multiple years of data. And that is really kind of one of the main strengths of the registry. And it's the ongoing contribution of data by people with CF that is key to unlocking further knowledge. With CF, it's kind of a self-sustaining research. With CF research, it's kind of a self-sustaining system. The more that we find out, the more that we realize we truly don't know. And hopefully there's going to be a lot more discoveries made in the future. And if Elaine isn't back, do we know if she's back? Okay, then I'll pass on to Susan Charman to talk about drug safety.
Hi everybody, I'm Susan Charman. I'm originally from Scotland and I moved to England about 30 years ago. So I think I still have a little bit of an accent, but I was the best part of half my life spent in England already. I've been at the Trust for 3 years now. Since lockdown, I've been sharing my home office here in Northamptonshire with 3 wonderful fox red Labradors, which I was hoping I'd be able to share a picture for you, but the technology didn't quite work as well as we'd hoped. This evening, I'm joined by Bonnie. I think Lola's gone down to fetch her con toy to show you a bit later. Okay, so I'm going to talk to you about how we use your amazing data and all the rich data sets that your centre teams provide to us to inform our drug safety studies. Now, you might be well asked why we would want to assess the safety of medicines using registry data. Surely safety is addressed in the clinical trials before the medications come to market. But there are 2 really important aspects to why we need to further analyse the safety of these medicines using the registry data. And the first main one is the time frame. Most clinical trials of any medicine, not just CF medications, are fairly short. It could be a year, it could be 8 weeks, it could be 6 weeks. I think the first ivacaftor trial was for 48 weeks, which is quite long for some CF medicines. But of course, in the real world of CF, having CF, you might take medicines for a much longer period. So we use the rich data we have in the registry and the fact that, as Andrew mentioned, we have it over several years to be able to conduct safety studies for a long period of time. It's important to assess whether in this setting over 5-6 years that the safety profile of the medicines are the same as they were found or no different than were found in the clinical trial setting. So that's the time. The other aspect is the setting. Okay, so clinical trials are actually quite restrictive in some ways. There might be some very restrictive inclusion criteria for people to be participants in a clinical trial. There may be age restrictions, there may be restrictions on whether you have any infections, whether you have a particular lung function at the time. But the advantage of the registry data is that it's a real world setting. You are providing your data to your registry teams, they're entering on the registry, and it's in the real world. That's really important to make sure that the medicines are assessed in that situation. Let me give you an example of where that real world setting is crucially important. A couple of the drug safety studies that we've been involved in have been looking at the safety profile of inhaled antibiotics. In a clinical trial, you might only be given that antibiotic and no other antibiotic. Whereas in the registry, we can monitor how the safety of that antibiotic in various regimens. So some of you might be taking an antibiotic alternating with another one, right? We want to make sure that the safety profile is okay when you are doing that, you're in that regimen, or you're being prescribed the regimen or that antibiotic with another one. Okay, so Andrew and Elaine have talked about some of the variables we've used for our annual report, for the banding. The other really important variables that we use, or information we use from your data, are things like the complications that you might have if you've taken a drug for a long time. And a really important aspect that we also look at in our drug safety studies is why you might stop a drug, a reason for discontinuation. And even if that reason is because your treatment is complete or you don't need it anymore, it's important that that data is recorded on the registry so that we and the companies that we are working with can assess whether there are any problems in taking these drugs for a long time in terms of adherence and other measures. So how do we go about doing these studies? It's a collaborative process. So members of the registry team will get together with a CF clinician from the UK, and we'll work with the company to set up and design the study. We'll write a protocol and a statistical analysis plan. And crucially, we will, in that plan, there will be a timeline for us to produce a series of analysis and reports and report to the company, who will then provide that report to the European Medicines Agency. So this report is assessed and reviewed by the European Medicines Agency, and along with our independent and analysis and interpretation, this gives you a full and sustainable view of the safety of the drugs that you're taking. Let me give you some examples of the studies that we've done. So our first drug safety study we did was was on a drug called mannitol, and in fact that finished a couple of years ago, and we're still awaiting the process to start about writing that paper up. So that was the first one, and that was over a 5-year period. We have recently finished the colibri study as well, and that was a 6-year study. And the first ivacaftor drug safety study was finished in people who were taking the drug who were 6 and over. That was finished 2 or 3 years ago now. And in fact, you can read about those drug safety studies for ivacaftor in some peer-reviewed publications. These were the first publications to result from our pharmacovigilance program. So once again, I hope I've given you a flavour of another direction of where your data is so useful, and I'm looking forward to answering any questions a bit later on. I think I'm handing over to Rebecca.
So just to keep you all on a knife edge, Elaine is back after her dramatic power cut and departure. So just before I speak to you guys about how the registry supports access to therapies, I'm going to briefly hand back to Elaine, who's just going to recap. I think it's hard for Elaine to know where we lost her, but she's just going to recap the very end of her talk. And also I think there was a question in the chat that she's going to address as well. Over to you, Elaine. You're on mute.
Thank you, ladies and gentlemen. I tell you, talk about never work live. I've been working all day in this office and nothing's gone wrong, but just in the middle of my talk, there was a power cut and everything went off. So I started pressing buttons really fast and hard to try and get back online, and finally I did. So just to complete what I was talking about, the tariff, I thought perhaps somebody had cut me off because they didn't like what I was saying. To cut a long story short, each band is given a cost and that was agreed by NHS England. The bandings are generated each year based on the annual data entered into the registry. Tariff first used in 2012 and then made mandatory for each CF centre from 2013. This ensures the centre is paid the correct amount for the care they have given their patients during the previous year. This method of payment puts cystic fibrosis at the forefront of costs for care, and the registry, and therefore your consent for yourself or for your children, ensures that CF centres get paid the correct amount to look after everyone with CF. Now, I know there's just been a question about high-cost drugs, and at the moment I can just report that high-cost drugs are not part of the tariff. They're paid for separately. So I hope that's a good answer. So I'm now going to hand back, after my excitement with the power cut, to Rebecca.
Thanks, Elaine. Hopefully I'm off mute. So I'm going to talk, hopefully fairly briefly, about how the registry supports people with cystic fibrosis across the whole of the UK having access to the best possible medicines as quickly as possible. And hopefully you're all aware about the impending Kaftrio availability, which has now been agreed across the whole of the UK, Scotland, Wales, Northern Ireland and England, to be reimbursed as soon as it's provided with its EMA licence, the current version of which will cover around 80% of the cystic fibrosis population. But actually the registry's been supporting access to therapies behind the scenes from the very beginning to get us to where we are now, and also to keep us moving in the right direction going forward. Right from the start, we conducted clinical trial feasibility requests. That's a kind of a bit of a mouthful, but basically what it means is that we provide data that's needed to support the right clinical trials being set up in the right way and at the right time. And we can also support recruitment to clinical trials, which can often be really difficult in CF when it's a reasonably small population and often several studies are trying to target the same people. The way we do that is by directly getting in touch with clinical teams who care for people with cystic fibrosis and telling them which of their patients are potentially eligible to participate, hopefully just cutting out some of the form filling and bureaucratic work that can sometimes be a real thing that holds up clinical trials running smoothly and quickly enough. Further to that, our ability to monitor medicines in the way that Susan's just described was a key factor in getting access to ivacaftor, also known as Kalydeco, a few years ago. And also in 2016, at the very start of that year, we also issued an open letter to NICE, that's the National Institute for Clinical Excellence. It's the sort of watchdog for pricing of medicines in England. And we suggested that the registry could be used to monitor not just safety, but the real world effectiveness of medicines in the long term. We were hoping that that solution would give payers and the commissioners of medicines like NHS England the confidence that they needed to invest fairly in the best possible medicines. And it's actually this solution, albeit several years later than we would have liked, that was the one that we saw Orkambi and Simkevi made available with late last year in 2019. And it's actually under the auspices of this same solution that the Cystic Fibrosis Trust proposed in 2016 that Kaftrio will be prescribed, hopefully very soon as the EMA license is granted. We'll continue to be working really closely with NICE, that's the National Institute of Clinical Excellence that I mentioned earlier. I'm glad they've got an acronym. And it's appointed Interim Access Oversight Committee to report on the effectiveness of ivacaftor, Orkambi, Simkevi and Kaftrio all over the next 4 years. So we're really bolstering the availability of those therapies and ensuring that NICE in due course has all of the evidence it needs to really truly understand the impact of these therapies on people with cystic fibrosis. Also, since 2016, there's kind of a few bits and bobs around the edges that we've done to help out where we can. We've been able to make available really detailed estimates of how many people will be eligible to receive all of these therapies. And that's really helpful to support negotiations and to enable decision makers to understand what the cost impact of investing in these therapies will actually be. In a lot of other therapy areas, doing these kind of negotiations requires quite a lot of guesstimation because they're not absolutely certain of the numbers. But the fact that every single cystic fibrosis team participates in the registry and 99% of people consent to having their data donated into it means that we can be really confident that our estimates are accurate, and that really helps to sort of oil the wheels of any negotiations. So also having these numbers to hand has also really helped the Cystic Fibrosis Trust and a huge community of campaigners, some of whom I've seen are here on the chat, so it's good to see some familiar names, even if I can't see your faces, to campaign for access to these therapies, because we all know it took a lot more than people around a negotiating table having the right numbers to hand. It was a real army of people working very hard day and night, hopefully appropriately armed with the data that they needed, which helped to push this campaign forward along with the efforts of many others over a number of years. So hopefully that gives you the idea that particularly when it comes to access to medicines, knowledge really is power and there's strength in numbers. And having a community asset like the registry to hold decision makers and industry to account really helped to open doors and amplify the voice of the community along the way. And that's across the whole of the UK. And right now we're working with clinical experts to catalyse a project to understand better the characteristics of those people who will not yet be eligible for a CFTR modulator. So the registry doesn't just speed up access to therapies that already exist, have already been developed. It can also help to characterise those people who currently don't have access to those effective therapies so that we can really refocus our efforts on them. So that's people who are currently not eligible because of their age, they might not be eligible because of their transplant status, or because of their mutation. And having the registry really means that that group cannot be forgotten and will not be. And we're working really, really closely with clinicians to make sure that we can describe those people as soon as we can. So I'm going to move quickly on to say a few words about our monitoring of coronavirus in people with cystic fibrosis, or COVID-19, which is what I tend to call it. So hopefully that's a familiar enough term for you guys. I'm sure it is for everybody. I won't say too much about this because actually we have spoken as an organisation quite a lot about our monitoring processes, and there's actually, I think there's a blog and a video to support this information, but I'm also really happy to answer questions if you do want more detail. So a quick overview is that we set up what we call our COVID-19 hotline. That's just our internal name in the registry team. That was set up in mid-March, so you know, quite a while ago this year, and that was to enable clinical teams to report to us directly in real time if they had any cases of COVID in the CF population. We thought it was really important to do that for a few reasons. One was that we really wanted to know about these cases as they happened, whereas the data that we get in the registry, as you've already heard from Andrew, is collected throughout the year and then reported on the following year. And we didn't think information about COVID could wait that long, and people with cystic fibrosis and their families needed information as soon as possible. So rather than wait for clinical teams to enter data themselves onto the registry, they let us know they had a case, and it was mostly Elaine would phone them up, get the information we needed from them directly and enter that data for them on their behalf. It was also really important to do that for respiratory doctors who obviously at the beginning of the pandemic were prioritising frontline care and maybe didn't have the time to enter the detailed data that we really needed. So we set that up, and for a few months now we've been reporting on the number of cases here in the UK on a weekly basis, just to keep the community as up to date as we possibly can. And the latest figures are that there are 28 cases of COVID in people with cystic fibrosis that have been diagnosed directly by the clinical team. So this doesn't include self-reported cases. These are only cases that have presented to their clinical team in hospital and been diagnosed. And I'm really pleased to say that 27 of those 28 cases have recovered from their infection and been discharged from care that relates to their COVID infection. So that's really good news. Unfortunately, and many of you will already be aware of this, one person has died of complications relating to their COVID-19 infection. And we actually don't release any more information about that person to respect the confidentiality of the family, who obviously now are going through an extremely difficult time, and also because it's very, very difficult to draw any conclusions based on a single case. In that 28 cases, we do have 6 children who are aged under 18 in that cohort. So we have a small number of children, but they're in that group who have all entirely recovered from their infection. You might also know that we are part of a global collaboration that now represents 18 countries, 18, from around the world, everywhere around the world, from South America, Europe, Canada, Australia, New Zealand, that are all working together, meeting every other week to have a chat. It's quite difficult to negotiate those time zones, but to discuss how COVID-19 is presenting in our CF populations around the world, because we know that the cases are actually reasonably low, and we think that that's because people with cystic fibrosis are very used to managing cross-infection and protecting themselves from infections. But that means we really have to band together to make sure that we can give people with CF and their clinical teams the information they need to understand how to cope with COVID-19 when it does present in someone with cystic fibrosis. We've already published a report on 40 cases. And that came out in April, and we are currently, literally, I was sending emails about it just before this call, working on publishing an update to those 40 cases that we're hoping to submit as a letter to the editor to get it out as quickly as we possibly can. But that includes 180 cases from 18 countries all around the world. That includes people who have had a transplant and people who are aged both under and over 18. So we're hoping that the information we're able to publish will give people with CF a much better idea of what decisions they feel comfortable making and how to make risk-based decisions on their own behalf. So as I say, we're hoping that that will appear as a letter in a peer-reviewed journal very soon, and you can rely on the Cystic Fibrosis Trust to promote that when it comes out, and we'll also be doing some explainers and things, because letters to a journal have to be quite short. We'll definitely be publishing more information around it so that you can get as much out of it as you possibly can. Okay, I'm just going to check our chat. So we are going to move on to a few questions now. So if you've got a question, a burning question for us, and you haven't put it in the chat, feel free to put it there. Amy is on hand to triage those questions to me, and I'll get them answered to you as soon as possible. But we did have a couple of questions that came in before the session, so I'm going to answer a couple of those. So I'll answer the first one, and then Susan, if you can answer the next one when I cue you in. So one of them was actually a really, really good question that I think sometimes we in the registry team forget to explain because it's our bread and butter, we do it all every day. And it was, who gets to see the data? And that's a really, really good question, because it's so important that we gain and maintain the trust of people with cystic fibrosis so that we can retain that really high participation rate, that we cannot at any time rest on our laurels about having that really high level of trust from you guys to look after your data. So just to make it really clear about who can access the data, the clinical team who's responsible for the care of an individual with CF, they can access the data that they enter about that person whenever they need to, just like they can access the medical records. But you can only access the data about someone with CF if you're in a clinical team, if you are responsible for their care. So basically only your doctors get to see your data in your cystic fibrosis centre. Other than that, there's kind of two categories of people who can access the data. One is the registry team. So actually not everyone in the registry team even has access to the database. That's restricted, even I can't see that, so that's restricted to the people on the team who are responsible for actually administering the data. So working with the clinical teams to answer queries about the data, check its quality. As Elaine mentioned earlier, she does visits to centres to make sure the data's at its highest quality. So I think there's only 4 members of the team, of the registry team, who access the data, and that's in order to administer the data. Anyone like me who doesn't actually need to see the identifiable data in the registry can't access it. The other kind of category of person who can access data in some form are the people who can access pseudonymized or anonymized data. So that's data that on its own cannot identify an individual, and that's the kind of information that can be accessed by researchers through the process that Andrew mentioned earlier. So that's very strictly governed by our Registry Research Committee, and researchers accessing those requests, those data to fulfill a research request can only access data that cannot identify an individual person. So hopefully that makes things clearer. If it doesn't, please, you can reply in the chat, and I'm happy to answer. It's the kind of thing that's sometimes easy to describe in written form as well, so I'm really happy to do that also. So another question that we had, just to give me a minute to check whether we've got any other questions coming in, was around, I think the actual question was about life expectancy, but I think Susan's just going to say a few words about what we mean when we're talking about survival in cystic fibrosis. So over to you, Susan.
Thanks, Rebecca. Yeah, the concept of median predicted survival age that we report in the registry is quite a difficult one to get your head around, essentially. And so we use the data from probably around 5 years of data in the registry to help us boost the numbers, obviously, because looking at 1 year of data might not give us an accurate estimate. And we basically calculate, well, we don't do it by hand, obviously, anymore. The computers thankfully do it for us. But so what the programming does, or the survival analysis does, it calculates lots and lots of probabilities of surviving an additional year, given that you're, say, for example, age 5 now, and we see you the following year in the registry, and maybe the following year after that, and so on. And we do that for all the different ages of the people in the registry in all of those 5 years. And then we do a fancy sum that multiplies all those probabilities together. And the result is this median predicted survival age. And it's really important to understand that that is an estimate of people who are born today. Okay, and there are certain assumptions around that calculation, in the sense that we are assuming that mortality and or survival rates will be the same going forward, and also it doesn't allow for any further improvements in care or medications in the future. Okay, so it could only get better theoretically then if we continue like that. Now, obviously that estimate of the median predicted survival age, that estimate of how long you'll survive on rough, or half of the people will survive to if when they're born now, that in some ways that's not particularly useful for everybody, because it might be interesting for somebody with cystic fibrosis who's 30 now, what's my expected life expectancy from now? But we are working on applying some of the research that Ruth Keogh has done at the London School of Hygiene and Tropical Medicine, where she has developed methodology to estimate these probabilities and the survival for people at a given age now. The slight limitation of that is, of course, that that will rely on the number of people who are that age in the registry at the moment. And so the accuracy with which we can estimate the survival of people at age 30 or 40 or 12 will be less accurate than the whole population. So I hope that gives you a better idea of how that's calculated. And it's important to realise that that's a different number to the one that we also report in the annual report, which is the median age at death. That's not a prediction. That's a number that comes up by analysing the age of people who have died in the year of the annual report. So that's an observed value. We observe these people in the registry, so to speak, and we calculate that age. So it's a very different type of calculation. I hope that helps, but if you want any more information, feel free to put a question in.
Thanks, Susan. So we've had another question, which is a good one to ask a team of nerds. It's, what is the best fact you've ever discovered in data from the registry? Now, Susan, get your thinking cap on in case you've got another one. I think I'm obviously going to cheat here and not name a single fact, because how can you have just one in this treasure trove of information that is the CF registry? I think it depends what you mean by best, I guess, but the one that the stuff that I like seeing most are the positive trends going upwards. So the beauty of the registry is that it's been running for a long time. It's been curated by the Cystic Fibrosis Trust since 2007. It existed in Dundee since about 1996, 1995. Elaine will tell me if that's wrong. So it means we've got really long-term follow-up for people with cystic fibrosis. And because of the healthcare system that we have, where people are cared for in specialist clinics, it means we very rarely lose people to follow-up, which is actually quite common in some other countries, depending on their particular health system. So it means we follow everyone over a really long period of time. And what's great about that is all of the various innovations in care, improvements in dietetics, improvements in physiotherapy, the better configuration of care being provided by specialist centres, improvements in funding that Elaine mentioned due to the tariff, new therapies that are available and new scientific advances. We're able to see over time, incrementally, year by year, that the median lung function for the whole population creeping up, BMIs becoming more healthy, more people getting access to CFTR modulator therapies, and ultimately more people living longer. Some of the stats that I really like to see that we actually were only able to introduce a few years ago, which says a lot, is the proportion of people with cystic fibrosis who are starting their own families. And I think for a charity, the Cystic Fibrosis Trust, I think that is an absolutely amazing thing to be able to report. And it's thanks to people with CF for participating in the registry, but thanks to the whole community for all of the efforts that they make in improving the health and life of people with cystic fibrosis. That means we're able to put that stat on a page, and that really means a lot. Oh, Susan's got one. Oh God, I'm out of the water with something technical.
Actually, and it's related to your last point about starting a family. So when we're doing these drug safety studies, or in fact any of the analysis we might need to do for data requests or gathering data together, or if we're cleaning the data, I might have to, so for example, ask Elaine to check on, say, for example, why somebody stopped taking a medicine. And what is nice when the reason is a nice reason rather than a not such a nice reason, and that is if a woman gets pregnant and they have to stop a certain medication. So even though that's quite small numbers, it's a nice thing to see.
Thanks, Susan. So we've had another question in from Rob, and he says, is the data only forward filled as you have clinic visits, or are things backfilled from your medical records? And I think Elaine's going to take that question for us.
Yeah, hi, thanks Rob. That's a really interesting question, and one I missed out on in my presentation. So basically we collect data from one annual review to the next, but at the end of each year, so at the end of 2019, we close the data down, we lock the data. That means that the data then that's handed over to the statisticians for the report and for data requests is clean, and it's not going to be different in the live registry as opposed to what they've got. So the answer to your question is we can backfill as we're going along. So in 2020, you can be entering data going back to March 2020 if you want to put encounters in. But as soon as we hit the end of 2020, then the data will close and you won't be able to go back. I hope that answers your question, Rob.
Thanks, Elaine. So we've had another question from Mark and Kelly. The question is, does the registry only measure physical aspect of health, or does it include mental health data? So there's a few ways to answer this question. I'm saying that to remind myself not to only say one and then go back on mute. So we do measure we have some variables in the registry that measure mental health. So things like depression and anxiety. I'll be honest, they're reasonably crude measures. So it's in the given year, has there been a diagnosis of depression? Yes or no. There are more detailed ways that we monitor the well-being of people with cystic fibrosis, and that's done in probably 3 key ways. So one of them is something that we've actually recently introduced, and it really supports the availability of medicines, but it will also be a really valuable research tool for the whole community. And that's to measure cystic fibrosis related quality of life. We've added that the ability for clinical teams to enter that data where it's measured in clinic. The survey is called the CFQR. You guys that might be twigging with a few of you. You might have seen that title at the top of a paper survey or an electronic form you've completed at some point. And the CF quality of life tool measures quality of life through 12 domains that are what's called validated. So it means it's gone through a really careful research process to make sure that it's asking the right questions in the right way. And there's a few different versions of it depending on your age. And we'll be collecting that data in the registry moving forward, which is something that I think will be really valuable in demonstrating what the impact of going from A to B is, whether it's a new medicine becoming available or a change in funding or a change in service configuration, that we'll be able to monitor that. We do also, our sister team, so it's in the same directorate as the registry, is the quality improvement team. Now this is different to mental health, but I just think it's worth mentioning now because it's another way that we try and make sure that whilst we think it's really important to get a detailed clinical picture of what's going on in cystic fibrosis, that we need to see people as a whole person, and that's not just about their clinical care. So the quality improvement team are responsible for monitoring and measuring patient-reported experience measures. That's also a sort of scientific term. They're called PREMs for short. What it really means is it's measuring a person's experience of receiving clinical care, because it is possible that someone looks quite healthy, but they might be not feeling that they're getting the right kind of care that they need. Or they might be quite unwell, but they feel that the clinical team is doing absolutely everything they can to keep them as well as possible for as long as possible. So that's a really important thing for us to measure and also feed back to clinical teams. So we've just finished the first round of collecting that information in paediatrics. So some of you, if you've got children with cystic fibrosis, you might have filled in one of those forms. If you did, thank you very much. We managed to meet our recruitment target despite services being disrupted by COVID. So we actually had to cut the whole thing short, but we still met our recruitment target. So that's real testament to people with CF for filling it in and the clinical teams for giving out that form. And it shows how eager the clinical teams are to understand the service that they're providing as well, which I think is really positive. And we're starting the adult data collection this autumn. We're obviously having to think about how best to do that when people may not be going for face-to-face appointments as regularly as they did previously, but hopefully you'll be hearing via your clinical team about how to complete that if you are an adult with cystic fibrosis very soon. And all of these reports will be published in the public domain, so you'll be able to see them, and as I say, hopefully as time goes on, get a truer picture of the full picture of what's going on in cystic fibrosis. I hope that answers your question. I can see out the corner of my eye we've had other ones coming in that I've not been able to check yet.
Rebecca,
yeah,
there's been a question on our from Nicola that come in privately to Nicola. The question was from somebody called Natalie. Does the registry record if patients have been diagnosed in adulthood or later childhood? And the answer is yes, because we have the date of diagnosis, and of course the registry has your date of birth, so we do collect that information.
That's what I was literally going to jump in on that one. There's also a question about data about the family, for example, single parents. We don't actually collect data on, we do collect data on marital status, and that includes not married, unmarried, but not particularly about single parents. That's right, Rebecca, yeah?
That's right, and there's a very good reason for that, and it's because we are strictly regulated, just like any research study, to make sure that we are only doing what is in line with the consent form that's signed by people with or parents. And what people are consenting to is for data to be collected about that person with cystic fibrosis. So whilst we can completely appreciate that contextual information about the family could be really interesting, we don't have consent to collect that data. So if we wanted to, we would have to amend our ethical approvals and change our consent form. So that's the reason at the moment that we don't do that. I can see another question from Nicole. Yeah, just checking I'm reading the right part of the text here. And it says, will the data gathered this year reflect the reduction in clinics and treatment for people with CF because of the need for hospitals to focus on COVID? It's another really good question. So we are monitoring the changes in clinical care due to COVID really closely and in a couple of ways. So one of them is that we are regularly checking the way that data are coming into the registry, and we're checking that against activity data that are available within the NHS in England. And essentially what that's telling us at the moment is that what's going into the registry is reflecting what's happening in the real world. So that's good news for us, because it means that we are able to accurately monitor the impact of COVID on people with cystic fibrosis. And what it's showing is that many annual review appointments, those MOTs that Elaine mentioned earlier, they are being cancelled. We're hoping that they'll start to be reinstated as the year goes on, but a lot of those have been cancelled. But we're seeing many, many more what we call encounters. So that is a interaction between a person with CF and their clinical team that can be at home or it can be virtual. Now, you know, for previous years, people have been able to record if an appointment has taken place and if it's been virtual. But not only have we seen on the registry a huge increase in the number of encounters that have been entered, but actually the proportion of those encounters that are recorded as being virtual has gone up by 400%. So what we're able to see is that clinical teams are pivoting and adapting to hopefully stay in touch with people with cystic fibrosis, even if it's not in the face-to-face way that they would ideally like. We're also able to monitor as people start to receive home spirometry equipment, which is being rolled out to as many people as possible, as quickly as possible. We can tell whether a value that's provided to us that measures lung function, whether that's provided to us with home spirometry or spirometry that's taken in hospital. And that's important as well, because we need to understand if there are any differences between the type of measurements we get in a clinical environment versus a home environment. Those checks that I mentioned that we're doing with NHS England are also really important, because they have access to some activity data that isn't necessarily stored within the registry. So we're able to see if people with cystic fibrosis are presenting to A&E, for example. That's not recorded in the registry, but that information is available elsewhere in the NHS, and we're working as collaboratively as possible as we can with other organisations to make sure that as a charity and a community, we can understand the acute impact of COVID, but also we can keep a really close eye on any kind of longer term ripple effects. It's a really good question, because it's something that is really on our minds at the moment, and it's something that we're working really hard to do. Have any other questions come in whilst I've just been chatting away?
Yeah, there's a CAFTRIO question, Rebecca, which I think you're probably best to answer.
Richard, is that the one you mean?
Yeah, the CAFTRIO from Richard.
Yeah, I just don't want to accidentally miss a question. So I could, but the agreement is nice. Could it take? Oh yeah, so that's a really good question. So the question is essentially, I mentioned earlier that we're going to be monitoring CAFTRIO for 4 years, and that's when the medicine will be reappraised by NICE. Obviously that does introduce anxiety about what will happen after those 4 years, but I think the thing to remember is that over the next 4 years, we're going to be collecting really, really detailed information about the impact of CAFTRIO. And, there's might be some people out here who already have some experience through yourself or through family, what impact CAFTRIO can have, and making sure that CAFTRIO at that 4th year is evaluated by NICE, showing a really true picture of just how much medium and long-term impact CAFTRIO can have, means that the decision makers are really armed with the information that they need to make sure that they can negotiate well, but also they can make the right decision that means that people with cystic fibrosis can continue to benefit from those medicines. So we can't say right now with absolute certainty what the outcome of that decision will be, but making sure that the best evidence is available really promptly to make that evaluation is as much as we can be doing to make sure it continues to be available. I hope that answers your question, and that's That's a little bit of a policy question as well, so I'm happy to chat with colleagues in policy who'll have more detailed technical information about that whole process that we'd be happy to point you in the direction of after the webinar. Are there any other questions? I think that might be it, and I think we're out of time. We're at 2 minutes past 8, and I think we were meant to finish 2 minutes ago. If you do have questions that I'm really sorry if I've missed them on the chat. It's surprisingly difficult to juggle keeping an eye on my team out here as well as watching for the questions. If we've missed anything, we'll do our best to answer them offline, as I think Amy's outlined in the chat. So for now, I'd just like to really thank you all so much for taking the time out of your evenings on a pretty hot day to not be outside in the sun, but to be listening to us chat about health data. It's really important to us, and I'm really delighted that it's been important enough to you to stay on the line for an hour. And as I say, we'll follow up on any questions we've missed through our channels. I'd like to let you know that there is another event coming up on Wednesday, the 19th of August, and it's called Returning and Settling Back into Education. I know that's an issue that's really important to many people in the CF community at the moment. With schools reopening in the next few weeks, there'll be an expert panel on hand to answer questions about going back to school and discuss the support that's available to get you there. You'll find a link to register, I think, in the chat bar. And so finally, I'm just going to finish off by saying that none of the work that we have described, but also none of the work that the Cystic Fibrosis Trust does in general would be possible without your support, entrusting us with your data, but also fundraising for us, donating your time and your energy to us as an organisation. So for that, we are all very, very grateful and very, very happy to have been able to spend part of our Wednesday evening with you all. So thank you so much, and have a great evening, and hopefully see you again soon.